This is The Rounds Table. All right, welcome back, listeners. A new episode, and I will be flying solo and covering the Confidence trial published in the New England Journal of Medicine in June 2025. The full title, which really bears no resemblance to the acronym, was Finerenone with Empagliflozin in chronic kidney disease and type 2 diabetes. So let's first set the stage. Current medical management for people who have chronic kidney disease and type 2 diabetes, right now the cornerstones are RAS inhibition, ACE or an ARB, SGLT2 inhibitors, and also, based on the FLOW trial, GLP-1 analogs. In addition to these agents, we know there's been multiple trials that have shown that Finerenone, which is similar to like spironolactone, it's in the family of MRAs. So Finerenone is another potential agent for people with type 2 diabetes and chronic kidney disease. That's 4 different classes of medications. And very few trials have looked at, okay, what if we start both an SGLT2 and Finerenone at the exact same time? Does that have additive benefits? And an important outcome related to renal disease, we very often think about what's this person's creatinine, how has it changed over time? But albumin to creatinine ratio, which is an estimate of how much protein is in the urine, that's a very powerful and important surrogate marker. It's not as powerful as a clinical endpoint like death from renal causes, but it's certainly, a relatively strong surrogate outcome. And really, what this trial sought out to do was to compare SGLT2, in particular Empagliflozin, plus Finerenone versus either of these two agents on their own. So let's dive into the methods. This was an industry-funded, double-blind, placebo-controlled randomized trial. The population were adults with type 2 diabetes. They had to have an A1C less than 11%. They had to have chronic kidney disease defined as a GFR ranging from 30 to 90, and a urine albumin to creatinine ratio somewhere between as low as 100 and as high as 5,000 milligrams per gram. They also had to be on max tolerated dose of ACE or ARB. A few key exclusion, I'm not going to go into all of them, but a few key ones: if they had type 1 diabetes, if they had a potassium above 4.8 at baseline, if they also had heart failure, or if they're already on an SGLT2 or an MRA. So the intervention, Finerenone plus Empagliflozin, and then the comparator groups were Finerenone plus placebo, and the other comparator was Empagliflozin plus placebo. The primary outcome was the relative change in the log transformed mean urine albumin to creatinine ratio up to 180 days. Log transformed, what on earth does that mean? Probably too much information. So if it's simpler, just think of the outcome as the relative change in the urine albumin to creatinine ratio. All right, let's get into the results. So overall, they screened approximately 1,600 patients and 820 were randomized. If we look at the baseline characteristics of the included patients, the average age was 66, 25% were female, half were white, average A1C was 7.3%, average GFR of 50, the average albumin to creatinine ratio is 600, that's a lot of protein in the urine, and 99% of patients were on an ACE or ARB, and 25% were also on a GLP-1 analog. So for that primary outcome of the reduction in the urine albumin to creatinine ratio 180 days, what did they find? So they found that combination therapy led to a 29% greater reduction than Finerenone alone and a 32% greater reduction than Empagliflozin alone. So pretty compelling data that the combination of these two drugs led to a much larger reduction in the urine ACR compared to either drug by itself. Serious adverse events occurred in 7% of patients, and these were the same across the 3 groups. Hyperkalemia occurred in 11% of patients if they just got Finerenone, 9% of patients if they got Finerenone and Empagliflozin, and 4% of patients if they just got Empagliflozin. And this actually fits with some prior data that suggests that Empagliflozin might mitigate the risk of hyperkalemia among patients who are on it, and in this case, in addition to Finerenone. In terms of the severity of the hyperkalemia, 95% of all of the hyperkalemia was a potassium less than 6. Said differently, 5% of the time, this was potassium above 6. And I think everyone will agree that a potassium above 6, that's really important to treat soon. Maybe calling it a medical emergency might be a bit of an overstatement, but no, I don't think it's that big of an overstatement. Secondary outcomes. One relevant secondary outcome was the reduction in systolic blood pressure. So it fell by 7 millimeters of mercury in the group on the combination therapy of Finerenone plus Empagliflozin. Okay, now, limitations. This is a relatively small study and a relatively short follow-up. Patients who are on these medications for their chronic kidney disease and diabetes, they're usually on them for many years. Often it's lifelong therapy, whereas this study only looked at outcomes by 180 days. Another important limitation is that this is a surrogate outcome. I really would have loved to see hard clinical endpoints, not just what was their change in urine to albumin to creatinine ratio. Instead, I would have liked to see death from renal causes, for example, and I acknowledge that would have required a much larger study, but it's unfortunate that the primary outcome was just a surrogate measure. So, how do I contextualize this? Most patients who have type 2 diabetes and chronic kidney disease, I would say, the vast majority are on an ACE or an ARB, and I think the next agent most should be on is an SGLT2 inhibitor. In practice, I sort of see that maybe 30% of patients are actually on an SGLT2 as well as an ACE or ARB, and it probably should be much higher than that. And right now in practice, it's pretty rare to see patients who are on Finerenone who have diabetes and chronic kidney disease, at least where I practice in Ontario. Part of that's related to how easy, or in this case, challenging it is to get access to that medication. But these data definitely show us that starting both agents at the same point in time definitely leads to a reduction in the urine to albumin to creatinine ratio over a 180-day time period. It doesn't really tell us anything beyond that because that's as far as the study went. The authors noted in their discussion this statement: stepwise therapy, so like one drug at a time, may prolong the time to effective treatment and can lead to clinical inertia. I definitely agree with that. In contrast, when you start 2 drugs at the exact same time and a patient has an adverse event or doesn't tolerate them, then it's a little bit of a tough sell after the fact to restart both of those. And sometimes it can be challenging to know, which of the 2 medications drove that risk. The other really important contextualizing point here is hyperkalemia. We know from prior studies that combining an ACE or ARB and an MRA leads to a markedly higher risk of hyperkalemia. And I have no doubts that the risk will be higher in clinical practice than what was reported in this clinical trial, because in clinical practice, you have sicker patients than those who are in a clinical trial. In clinical practice, we can't monitor patients as closely as we do in a clinical trial. So I think really it's going to require really careful patient selection. And then what I tell my trainees, and also how I practice, is I think if my mom or dad had chronic kidney disease and diabetes, how would I want them to be treated? What medications would I want them to be on? ACE inhibitor, yep, of course. SGLT2, yep, of course. And would I want another agent like Finerenone? I'm not sure. I think the answer is probably yes, but it's a sort of a fine dance, a bit of a balance, and knowing your patient's preferences and how many medications they want to be on. Like, are they a maximalist? Yeah, doc, give me everything. Or a minimalist? Doc, I hate pills. Only give me exactly what I need. That's really important to know when we're talking about the risks and benefits of these medications. Anyway, I think that's all I have for this trial. I hope you found it helpful. For any of the listeners who might be trainees, med students, residents, especially from med schools outside of Ontario, the rounds table as well as trial files. We're looking for, ambitious, eager, keen trainees who are interested in contributing and helping with either the rounds table or trial files. So if this is of interest to you, definitely reach out to me. The easiest way is through Gmail, and it's fralickmpf, as in Frank, @gmail.com. All right, that's it for today. Thanks so much, everyone, and I hope you learned something new.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.